Okay, it's a recording in progress. So good afternoon, everyone. I'm Paul Lynch. I'm a senior lecturer in early childhood development and disability and inclusion. I'm based in the College of Social Sciences, but I work with this team over here in the corner. And I'd like to do a short presentation on a research project I'm involved in called INDIGO, identifying and supporting families and children with disabilities globally. Pick out the letters to make INDIGO. You know, with MRC studies, you have to think of funky ideas. So here's the team. We have a team from the UK, Uganda, Pakistan, Canada, London School of Hygiene, and University of Lancaster. And just to give a sort of global context, that there's about 16% of the world population has a disability, which equates to about 1.3 billion people. So it's just a recent global report on disability that's just come out by issued by WHO. It's a year late, but it has increased from 1 million to 1.3 million. And globally, we're talking about 1 in 20 children having a disability, and 53 million under the age of 5 years have moderate to severe disability. So you're probably aware of the fact that early identification and treatment of a disability or developmental delay really makes an important difference to children under the age of 5. And even earlier than that, if we can identify the developmental delay quicker. So 90% of our brain growth happens before the age of 5. So you can see why it's really important that we identify the disorder and the intervention. Yeah, come along. Come and join the crew. So, as a lot of us are aware that disability is not always visible, it's very often invisible. And so we need to find, particularly in low and middle income countries, that services for invisible disability, for example, autism, ADHD, intellectual disability, is not really adequate in many of the countries, particularly in sub-Saharan Africa. So a recent report included identified 240 million children having disabilities, which means 1 in 10 in the world. So that is really significant. And if we look at the hotspots, we can see that South Asia has a significant number. But also, if we combine East and Southern Africa and West Africa, which is somewhere behind our screen here. That's a great. There it is. So if we combine the two, it makes the biggest proportion of children with disabilities. So the Lancet report the first one is in 2006, identified around 250 million children not reaching their developmental potential as a result of stunting and malnutrition. So that was one of the major causes of developmental delay. And moving to a UNICEF study, which uses what's called the Washington Group questions. These are a set of questions that don't talk about disability as a term. They talk about functional difficulty or functioning. So rather than say, does your child have a physical disability? Does your child have an intellectual disability? They say, does your child have difficulties in seeing, in hearing, picking up things, playing? And that makes a lot more difference for parents. And what's also interesting is that a lot of countries in sub-Saharan Africa focused on the visible disabilities, and they are lower in terms of percentage. Whereas communication, learning, and controlling behavior are much more significant. What also is significant is more than one. So the comorbidity of having a seeing impairment but also not being able to walk or play or fine motor control. So think of a child with cerebral palsy will cut across more than two of those. So a colleague of mine, Professor Melissa Gladstone, has done a lot of work, and I've been sort of doing work with her, that a lot of the tools that we have in identifying children, assessing children, like the Baileys, the Griffiths, ages and stages have been developed in Northern Hemisphere countries like the UK and United States. And so a lot of these Western screening tools are not really appropriate for sub-Saharan countries like Malawi. So we've done a lot of testing, and this project that we did was looking at ways of identifying key skill questions that we could ask in rural populations of sub-Saharan Africa. So one tool that's been developed is the Malawi Development Assessment Tool, which is a mixture of the Bailey scales and the Griffith scales. And as you can see from the map, that it's been used in more than Malawi. It's been used in over 20 countries. So it's been validated. It's been seen as very specific around identifying moderate to severe learning difficulties. And the particular study that we undergone with funded by the Medical Research Council was to create a synthesized version of MDAT with core developmental and additional items, measuring vision, hearing, hydrocephalitis, and other spina bifida, etc., and cover all the elements of the WHO ICF children and young persons guide. We wanted to understand processes needed to conduct a diagnostic study, including a gold standard assessment of neurodevelopmental disability suitable across 3 low resource countries, Malawi, Uganda, and Pakistan. And we field tested the tool. So I'll just talk through a bit of the process now. So a lot of you are aware of the ICF. I'm just reminding you that we tried to map a lot of the research that we do against the ICF using the biopsychosocial model, which integrates the social model of disability and the medical, the biopsychosocial. And what's really important is, if you looked at a previous version of that looked at handicap, this doesn't talk about handicap, which is a really not appropriate word. It talks about participation and activity, and also how they impact on environmental factors and personal factors. So if we take an example of that, a child with a cleft palate, which is quite a common impairment in Malawi, for example. If we apply the ICF framework, we have a child who has cleft palate, has problems with eating, forming relationships because of the way it looks, the facial problems that creates in terms of how that child is able to function. But then in terms of environmental factors, exclusion from ceremonies, so community ceremonies, because they look different, and they don't, community don't want someone who looks different in say a wedding or a funeral. And then later on in life, unable to form partnerships and have children. And so it's a really useful framework. So the first thing we did was to create, we went through about 19 different tools, 1,453 items. It was very laborious that we shared it between pediatric psychologists, inclusion people. And so we mapped the different areas of ICF, environmental factors, activities, so you'll recognize the ICF, and the different function like voice and speech, general tasks, communication, mobility. And what we did against keep your child on a structure or routine, that was one of the skills for one of the tests. What age range? Well, it's around 13 months plus, and it refers to body functions, activities, but not in environment. So we did that. quite a laborious but really important step. And so we came up with items that we chose as prior to consensus. We had a consensus meeting when we all met together to agree on which items we felt were specific, that had a high reliability in terms of identifying a developmental delay. So we looked at nervous, oh gosh, yes, eyes, ears, movement, bones, etc., epilepsy, sleep, vision, hearing, and language. So we wanted to create a gold standard assessment to identify children, so identifying those areas and adding on extra assessments like the HI, which picks up on cerebral palsy, vision testing, hearing, medical exam, and anthropometry, and then different areas of cognitive development, etc. So our question was, which items on MDAT plus extra have good sensitivity and specificity for identifying children with disability and specific group of disabilities in children under the age of 3 months, 0 to 3, and then also 0 to 3 years. Those were our sample group. We had 102 children in Pakistan, 150 in Uganda, and 97 in Malawi. And that's where our recruitment and which ones we kept, the risk criteria, those that met the risk criteria, and those children. So our goal was 160 children, which we met. So the diagnostic accuracy to identify items, which worked. So we looked at each country in terms of norm and against the different functional impairment. So we found that there were quite similar results between Uganda and Malawi. However, Pakistan was lower. Just to say that we went to Karachi. We worked with Aga Khan University, and they are based in Karachi. So these were more city-based children. And also there's a paper that I've published which talks about stigma and discrimination. And we found, particularly with the middle-class parents, that they weren't willing to have their children diagnosed or even taken out of the home because of stigma. So that might be a reason as well, because of the lower numbers. We then looked at the accuracy in terms of what questions we thought were good diagnosis and bad diagnosis by mapping the specificity and diagnosis against the age, the decimal age, and the possibility of correct diagnosis. So we see that being able to crawl in any way is a good question to ask for children on a normal trajectory, but also children that have possible diagnosis. So the gap is quite low, quite narrow, whereas this is a bad idea to ask smiles, but not in a particular person. That is not a very good question to ask, because children can smile at anything at any time. So the test, the diagnostic test, it should only take 20 minutes. It takes part A is family questions, asking about the history of the child, the birth weight, gestational age, corrected age, etc. Questions about the physiology, whether there's a bump on the spine of the child, whether the eyes look different, cleft palate, hydrocephalus, and microcephaly as well, small head. And this is the tool that we condense. So it's a really condensed tool from the MDAT, which normally takes 45 minutes. This should take 10 minutes. So we really brought down the number of skill areas down to these, okay, quite specific. And as you know, when we do, so for a child at 24 months, we go back to 21 months and start there and work our way back up again. And if we find that a child has failed in more than 2, it's referral. If it's 1, we go back in 3 to 4 months and do that again. And if it continues to be a problem, we will recommend for referral to the clinic. So next steps. So we're looking at doing some more work around developing a framework, a TDF framework. We've done some more literature review, situational analysis. So we want to try it out in more areas in terms of scale up to look at behavior change. But what's really important is the engagement of stakeholders. We have a test that is very simple to use. It doesn't require a psychologist or a pediatrician. It requires a paraprofessional, community nurse, or even a teacher, but they need to have some training in order to administer it and feel confident that they can pick up on certain signs, that they can really interview the parent and make the parent feel at ease, that they don't feel worried about the questions. So it's really important about co-working with caregivers and implementers to make sure it works. And this is sort of where we're moving towards. We want to pull in another grant in looking at early childhood development workforce. So the different options, do we look at standard care if children are not showing up as having a developmental delay, or just one area that we could do, sort of keep an eye on them, look at ways of developing community parent groups to support children in their local communities. And I'll stop there, and that's my team. That's the team. We had a meeting in Uganda, in Kampala. We also worked with Makerere University and the KUHES in Lilongwe in Malawi. So I'll stop there. Thank you.
Are there any questions from the audience?
Hi, thanks. Yeah, Peter, the person, really nice talk. And so it's sort of a two-part question. And
sure.
And so what you're trying to do, I guess, is make a simplified tool to increase diagnosis, by optimizing for sensitivity. But I guess, like, those kids with very obvious things may have been identified earlier,
Sure.
Anyway, the issue is maybe not the identification, it's actually there's no services for them to be referred to. So is optimizing for sensitivity actually going to improve outcomes or not? And I guess the second part of that is I wasn't completely clear from the data collection. It looked like you had a kind of a case control sort of design where you had sick kids or kids with disabilities and healthy kids. And doing that tends to introduce spectrum bias where you kind of overinflate sensitivity already. So what I guess I'm getting to is you might identify a lot of kids with milder sort of disabilities who then kind of overwhelm the very resources available.
Yeah, so in answer to that part of the question, we did recruit a high number of children through the clinics who are already attending clinics, particularly children at low birth weight. So we were picking up, we were sort of, it was quite difficult to recruit outside, and you know, with these this was just like an 18-month grant. We were really restricted in time. We, in terms of inflated, we did pick up quite a significant number of mild disability. I think the numbers in Pakistan were particularly interesting, and that we didn't. And again, it's because a lot of the children didn't present at the clinics. Although we went to a special school, so we did actually target some schools that were used through key informant method to find children. So there were children who had been reported having a developmental delay, but we used this to confirm it. So it's almost like confirming what parents may know. And the previous MDAT is just far too difficult, far too expensive to use. So the idea with working with Melissa is we've used the MDAT countless times, but it just hasn't been seen as a scalable test, even though we've had lots of studies. This is our chance now to really just cut down, reduce it. And we do need a significant number of more children and go out into the rural areas to test it more.
Okay, are there any questions online? Oh, yeah. Paul Lynch. Any other questions from the audience? Paul Lynch. All right, thanks for timing. Thank you very much.
Thank you. Cheers.
Sorry, we're trying to follow the order.
Hi, so I'm Laurence Moore. I'm Director of the Social and Public Health Sciences Unit up on level 4. Delighted to be asked by Hamish to present at one of these cross-theme seminars. Yeah. I don't do a lot of research now. I mostly do managing. So this project is not completely fresh. This was published actually about 18 months ago, but I don't think it's been presented at the cross-theme seminars before, and it's relevant particularly to the solution focus theme, but very relevant to all of us in the school, I think. So I thought it was worth just kind of running through it quite quickly, and I'll mention at the end some further resources if you want to find out more. So I'm here speaking on behalf of a team. This involved Catherine, Lindsay was with us in the unit, Sharon, Peter and myself from SPHSU, but also we brought in some health economics expertise from Kathleen and Emma, as well as working with others who'd been involved either in previous versions of the MRC guidance or were in significant roles with funders and it was funded by the MRC and the NIHR to take this forward. And also Neil from Public Health Scotland also had contributed to health economics. So very much presenting on behalf of the team across school team. So why did we do this? Well, first, for those of you not familiar, in 2000 was when the first guidance was produced on how to go about developing and evaluating complex interventions, the kind of interventions that we, those of us involved in intervention research in this school tend to focus on. And that focused on how you develop studies to interventions to the stage at which you can then do a randomized trial to demonstrate effectiveness. And it really kind of translated the stages of drug research to the kind of ways in which we might apply the same kind of ways of thinking to these more kind of complex interventions in social and behavioural clinical kind of sciences. That came out in 2000, was enormously influential. This is a number of citations, so it's kind of been on a slow burn, but it's been kind of heavily cited over the years. In 2008, there was an update of that guidance, which Peter Craig led, and that's now been cited. I just checked, it's been cited over 11,500 times. And when we were doing this work, it was still being cited at least twice a week. So it's still being very heavily used globally to inform intervention research. These are the kind of the main diagrams from the first two versions of the framework. And as you'll see, it was very much those of you involved in the different stages of developing drugs and preclinical work, phase 1, phase 2, and then the definitive phase 3 randomized trial. That was still the kind of basis of the guidance. Even the later updates still had these stages, even though it recognized you might go back from feasibility to further development or evaluation to further piloting. It still involved these stages of research, and one of the motivations for us, but also the funders who asked us to take forward this latest update, was the recognition that many of the most promising interventions, certainly in my area in population health, public health research, but also in health services research, can't be evaluated in this way. So service and policy innovation, complex population level policies, you can't really take forward in the same kind of set of stages that the guidance was saying, and that was based on what you might do as a researcher-led team developing a new drug or a new kind of individual level intervention. And there was also a lot of disenchantment because there was more and more studies being published which had gone through these stages of research, had done a definitive controlled trial to demonstrate effectiveness, and then it was found that the effective intervention actually kind of failed to replicate those outcomes in the real world, either because they weren't really implementable in real world circumstances, or there was a whole set of reasons why there would be implementation failure, or that even if it did work in some places, it was not transferable about contexts, transferable across contexts and different kind of settings and situations. and the way in which the interventions have been developed and evaluated wasn't giving us any information to understand that context dependence or what would be kind of implementation factors or mechanisms that needed to be in place to replicate the outcomes. The other thing we were aware of was lots of interventions, when you introduce them into the setting, may produce some of the direct outcomes that you had modelled and evaluated in the effective research, but also produce a whole set of other impacts on the wider system that often crowded out the proximal outcomes you were hoping to achieve. So these are my all kind of system level factors. The way in which contexts were dynamic and responsive to interventions was also something we weren't really taking account of in the work we were doing as promoted by the previous guidance. So a lot of people were saying, well, this guidance is great. It's really helped develop the field. We're having a lot more intervention research going along, a lot more trials for complex interventions. But actually, is this not just a production line of researcher-led effective interventions that are limited in terms of implementation requirements and stakeholder insights, so generally actually don't work, don't produce health gain in the real world? So lots of concern about that. Another major area of concern was this lack of taking account of kind of like systems thinking and systems approaches. I was part of this editorial in the Lancet where you know there was a call for us thinking more about systems approaches. And if we thought more about systems perspective to our intervention research, it could both lead us to take account of the wider contextual, both static and dynamic contextual factors within which an intervention is implemented that then determine whether the outcomes we're hoping to achieve are actually achieved. And also taking a systems perspective actually encourages you as a researcher, but also funders, practitioners and policymakers to actually think about how we intervene at the more macro level of the system, or take a whole system kind of intervention approach rather than continually focusing our intervention efforts on kind of individuals or very kind of downstream parts of the system. And if you take that kind of systems lens, it also it changes the focus of your intervention in the way I've just said, from targeting individuals with interventions to bring about change in those individuals towards that kind of upstream action to create conditions and environments that support healthier behaviour or other kind of healthier outcomes. And also by taking a systems perspective, it moves you away from thinking about one-off brief interventions to actually interventions that are going to be more systemic, to have impacts that are sustained, and that the kind of ongoing actions of the interventions are sustained in the real world, in the context, the clinics, the wards, the health systems, the schools, the workplaces, etc., in which you're hoping to bring about change. And when you're thinking about systems perspective and thinking about evaluating things in this way, it changes your question, really. It changes your question away from trying to identify silver bullets, the interventions that will be effective and will solve the problem. We're continually searching for these silver bullets, whereas actually, in reality, we often need to take lots of multiple actions. No one intervention is going to really bring about the change we want to. And we need to kind of evaluate both individual level, but more system level or whole system interventions more in a way that sort of tries to identify, does this intervention contribute to bring about better outcomes, either at individual or at system level? So moving away from effectiveness questions to other kinds of questions based on contribution. So with these kind of background concerns about the kind of research that was coming out in intervention research that was being kind of was following the previous kind of guidance, we and the funders felt it was important to do this kind of update. We wanted to have more work on thinking about what do we mean by complex intervention. It's not just the intervention is complex, but it's also the relationship between the intervention and its context is where a lot of the complexity really arises. We wanted to emphasize the use of diverse research perspectives, so not always thinking about efficacy and effectiveness, but thinking about contribution, using theory-based approaches and systems-based approaches to understand that a little bit more. To shift the focus to producing evidence that's useful for decision makers and using that kind of frame to think about what is the critical research question here. Is it always to identify effectiveness, or is it to think about other questions related to that? And then the other thing we wanted to do is make sure we won't just privileging new interventions that are being developed from scratch, typically by researcher-led teams, but we were also thinking about how we applied this kind of guidance to other types of interventions, particularly more upstream policy level type interventions. So the previous guidance had mainly related to the idea that you develop an intervention, test it for feasibility, do a definitive trial, synthesize your trial evidence, and then policy action would be brought about on the basis of that. But if we're looking at more kind of policy level kind of interventions, there may be you're kind of developing the policy, you're thinking about, you know, in government or in if it's a health change in health services delivery or something like that, you decide what you're going to bring about, what change you're going to bring about, and then within the implementation of the change, you think about how you can evaluate it, usually using some kind of natural experimental design rather than setting up a researcher-led RCT. So these are both really important ways in which we generate evidence in population health and in healthcare. The original guidance only really focused on this mode of research, whereas a lot of us are doing these more natural experiment type approaches. So we wanted our framework to include that approach too. So how do we go about it? We went through a fairly kind of formal process of stakeholder involvement, systematic information gathering and feeding back to a wide range of representatives who are involved at different stages in telling us how well we were getting on. And what did we come out with? What's new? So I've already said this really, but what's new is we say, you know, when we evaluate interventions, it's not, the only question is not just does this intervention work either in tightly controlled experimental settings, efficacy, or in more pragmatic circumstances, effectiveness, but actually some other really important questions like understanding how the interventions work, in what circumstances, and how does it bring about change, a more theory-based approach, and also really thinking about a more kind of systems perspective to evaluation, to think about how we're bringing about system change and whether the intervention introduces change to that dynamic system in a way that brings about lasting benefit. We're not saying that the previous kind of efficacy and effectiveness questions should be thrown out and are no longer useful, but for certain types of research, there's still, that is the question, that's a really important question, but therefore other types of interventions or other stages of research where some of these other questions are and approaches are very important. So the new framework looks like this, and the key sort of changes I'll just talk through briefly. One I've already highlighted is we say it's not just about developing new interventions. It's very rare that we come across a situation where there's no existing evidence at all and we need to start completely from scratch. There's usually existing interventions that can be adapted. So adaptation, so development and adaptation of interventions is where we might get our intervention ideas. And also we might be working with policymakers or healthcare providers and identifying interventions they're thinking of bringing about and making sure we evaluate those. So coming into the system, the development stage is not just always starting from scratch with a researcher-led development process. And then the other thing we do is we say we don't necessarily think how we would seamlessly move from one stage to the other. We actually do maybe the development stage, and then we think about these core elements. And we use these core elements to decide whether we still need to do a bit more work at that stage or whether we're ready to move on to another stage. And even when you're in implementation, you might be finding stuff there that leads you to think you need to kind of go back and do a bit more adaptation or refinement, or to do a bit more theory-based work or evaluation work. So this idea of these core elements as being things we continually need to think about to try and improve the usefulness of our evidence for decision makers. I haven't got time to talk about each of these core elements in detail. One is very much thinking about different aspects of context, and this, of course, is critical to thinking about, will the intervention work here? Will it be successfully transferable to different kind of contexts? Part of that is having a program theory and think about we need to explicitly develop a program theory, and all the data we're collecting throughout all these stages is helping us to refine and improve and update our program theory, which includes the logic model bit, but it also includes the context dependence bit. We need to do this with stakeholders. So a big part of the new framework is recognising that not us academics, we know quite a few things, but we don't know everything. We certainly don't know everything about the systems in which interventions are going to be implemented. So involving them at all stages, including right at the beginning, is really critical. Thinking about all, the reason why we keep addressing those key uncertainties is thinking about, given what we know now, what's the critical research question now? And it might be to find out a bit more about context. It might be to think, how can we refine things a little bit just to improve the acceptability of one part of our intervention? So continually thinking about what we know now, what's the critical research question to address next based on what the critical uncertainties are now. Recognizing that, we need to be responding to our evidence, to our updated program theory, to continually refining and optimizing our interventions is part of what we need to be thinking about. And also, the previous guidance was very light on health economic considerations. So the reason why Emma and Kathleen and Neil were involved is to increase the extent to which we thought about resources, both in the value of research and then also in terms of the health effectiveness, cost benefit type questions that we ask, and particularly thinking about taking a broader kind of perspective to the economic appraisal of these types of interventions. And then the final thing that I want to highlight that's new is that previous versions of the guidance and even new guidance is often referred to by people. I was just on the Applied Global Health Board at MRC the other week, and lots of people were referring to the new guidance, and actually what they've written, there was no evidence that they had read the guidance. So we brought in this checklist, which really helps researchers, but also funders and peer reviewers to actually see how people have used the framework in the work they have done. So the main outputs were the long version is the HTA report, short version was in the BMJ, and that, even though that was published, say about 18 months ago, it's already been cited 1,150 times. So our little red tick is coming up, and the old guidance is still being cited quite a lot, but less. Thank you. Any questions? Prof Moore? Yeah.
Hi, we're just in the process of phase 2 of one of our complex clinical trials. And I just wondered if you could say a little bit about how to determine whether to do an RCT versus a realist evaluation. Any suggestions?
Well, it's tricky. I think look at what are your key uncertainties. What are the key questions you really want to answer? I mean, if effectiveness is one of those questions, then are you ready to sort of do the trial, or do you still need to really understand a little bit more about the process? So you might do a bit more theory-based work before. I mean, what you can often do in some of the trials I've been involved in is where you combine the two. So if you involve quite a bit of process evaluation, both qualitative and quantitative, and if you've got a good program theory, and there's different ways of addressing both through the process data and the outcome data, some questions in addition to just what's the average unbiased effect, then you can do what I've termed, there's a whole load of papers where we've talked about the idea of doing a realist trial. So you bring different sources of data together, so you're still getting the unbiased estimate of effect, but you're collecting an awful lot of other data about implementation, process, dose, this kind of thing that can enrich your understanding of what's going on.
I guess then why do an RCT? Just to bring that back. Our fear is if we went from an RCT to realist evaluation for a phase 3, we would find it hard to then go back to engaging services to do an RCT. So that's a
yeah, I mean, it's tricky. I mean, we've tried to introduce the idea there isn't just one thing to do, which traditionally used to be the effectiveness thing. I mean, clearly decision makers, the thing they value most is having that estimate effect, a number that they can be confident in. But as we've shown, what was one of the key motivations that the research councils and the research community were sort of saying, well, we're doing these trials, we're finding these effect estimates in our trials, but then they're not being replicated and we don't understand why. And what we need to do to make sure they are replicated in different circumstances. So you do need the both. I'm happy to discuss it further. And also I was going to mention, we do occasionally do different workshops and conferences, and twice a year we run a course that you can book onto through the National Centre for Research Methods. So we advertise it through them. There isn't a date yet. There will be another course in November sometime. So if anyone wants to do that, it's a 5-day course that we'll run here.
One last question before we move on.
Thanks, that's great. Perhaps a provocative question, but maybe the most impactful trials in the last decade have been doing COVID vaccines and steroids, and did those trials follow this approach? And if they didn't, you know, what extra benefit might we have got if they did use it?
I think with drug trials still tend to very much focus on the efficacy, effectiveness question. And that's a legitimate thing, because that is the main question they're looking at. I think what we see in that drug research and development role is the greater awareness of personalized medicine, and that's the kind of like the equivalent, really. So we talk about context as being massively important for how our kind of more social and healthcare and public health interventions work. I mean, in the drug world, it's more your genetics and other kind of factors that mean each of us as individuals respond very differently to drugs. So I think some of those COVID drug trials, and certainly what we need to understand more, particularly in the context of long COVID, is why COVID has different impacts on different individuals relating to a whole set of circumstances. So understanding that variation in effect is really key. That would kind of, what's the unexplained heterogeneity? For us, it's often the contextual stuff. In the drug world, it's probably these genetic and other physiological and existing conditions.
Great. Thank you very much.
Thank you.
Okay. Last but not least, Dr. Katie Gallacher, would you like to introduce yourself? There you are. Slides out.
Well done. Okay, hi everybody. Thanks for still hanging around for the last talk. I'm Katie Gallacher. I am a senior clinical lecturer in general practice and primary care at the School of Health and Wellbeing. So we're on level 3 of this building, and I'm also a GP. And I'm going to be talking to you today about a systematic review that we've done of burden of treatment theory. So before I talk about the theory, I'll just give you a bit of background of burden of treatment, because not everybody here will be familiar with the term. When you manage a long-term condition, it can take a lot of work for the person who has a long-term condition. So the workload undertaken to manage health for people with long-term conditions and the impact that this has on your well-being is what burden of treatment is. So that's how it's defined. And it's becoming increasingly important. People are living longer, they've got multiple long-term conditions, and obviously if you have more long-term conditions to manage, you're more likely to feel this burden of treatment, more likely to be affected by all the workload that you have to do. And of course, everybody's different, so even one person at any point in time has a different capacity to manage the workload of healthcare, and there's a great variation between people, and that's affected by lots of different things, the situation at the time. So if we think of burden of treatment like a sort of balance between this healthcare workload on one side and capacity to manage health on the other, if the balance tips towards the workload being too heavy and the capacity being too small, then that's why when the person may feel burdened by their treatments. So burden of treatment theory is a theory that seeks to understand how burden of treatment might arise. So it explains the relationship between the person, their social networks, all the people that they're interacting with, and the healthcare systems. And it seeks to illustrate how a variety of different factors in these relationships can result in somebody feeling burdened by their treatment and can affect their experience of managing their health. So I'll run through this is the theory sort of broken down. It first of all talks about mobilizing capacity. So this is really about taking advantage of the opportunities that are available to you. So all the services and opportunities that are there. Whether you can make use of them will depend on how they're set up and how they're provided. It will also depend on you and whether you can access them yourself. It also talks about expressing capacity. So that basically means all the different things that could affect your ability to manage that healthcare workload. So for example, if you've got, if you're well off, if you've got a lot of people around you, if you're well educated, then these things will all help you to be able to manage your health and make life easier. And then it talks about mobilizing for and enacting delegated tasks. So that basically means these are all different tasks that you have to do. And they can be broken down into sense-making work, which is self-explanatory, sort of making sense of healthcare and learning about it and understanding how you do it, interacting with others, so that might be health professionals or friends and family, the actual doing, so taking medications, attending appointments, and monitoring your progress. So we were interested to find out how burden of treatment theory has been used in literature. So we wanted to identify the different ways it's been used. We wanted to explore the theory's contribution to advancing knowledge regarding treatment burden and capacity issues. And we wanted to see if there was any critiques or limitations of the theory. So basically, we searched very widely. So we didn't want to just limit it to healthcare. We looked for any paper that had cited the original burden of treatment theory paper. And we did social science databases as well as healthcare ones. We were open to any type of research articles, protocols, or preprints, and very wide-reaching. We excluded, as you can see along the bottom, editorials, letters, abstracts, theses, or dissertations, but it was quite a broad review. We did quality appraisal using different checklists depending on the type of paper, but they were all validated checklists. We extracted sort of pertinent data from it. As I said, we were very interested in the use and application and discussion of the theory itself. And we did an inductive thematic analysis to identify themes. So we found 613 papers and whittled that down to 29 that met inclusion criteria. And as you can see, there was a lot of different kinds of paper. Most were qualitative, some systematic reviews and protocols, discussion papers, and then a few other ones on the bottom. So the majority of papers that we found were from the UK, and that's where burden of treatment theory was developed. So that's not surprising. But there were some diverse, the other countries were quite diverse. So there was Australia, Norway, Argentina. There were systematic reviews from the US and Europe, and there was, as you can see, there was Malawi as well. And the research focus of the papers were mostly to understand and sort of characterize the experience of treatment burden. And there were others that were looking to develop interventions and improve service delivery. And there were a broad range of clinical settings, and there was actually one non-clinical setting, which was the development of a domestic violence intervention. So that was interesting. We did note that 17 of the 29 papers had authors who were on the original burden of treatment theory paper. So there were a lot of people on that author list that were doing the research, but there were others as well. So application of burden of treatment theory. So we just wanted to know, what did they use the theory for? So there was a mixture of things, but the most common were to underpin their data analysis or inform data collection methods, and then to inform the intervention development. And there was one that framed a case study discussion, which was the only case study paper. There was a bit of a mixture, so it seemed quite fairly common to sort of mention that they'd used the theory and then not really have much discussion around it. There were 9 that just mentioned it and had no discussion at all, 8 that had a little bit of that, a little bit of rationale, but there were 12 that demonstrated a high level of engagement with it, which was nice to see. There were 2 papers that had adapted it. So the paper that was looking at the domestic violence intervention had adapted it to be suitable in that setting, because it was designed to be used in a healthcare setting. And the Malawi paper, which was the only low middle income country paper, they added on a domain which was lack of treatment, because they felt that was missing. And the theory was obviously developed in the UK, where there are NHS services. So that was an interesting add-on. We found that the level of sort of critique was it wasn't very in-depth. Within a diplomatic way. It was quite broadly, they were sort of broadly described. So there were things like, well, this fitted well with our findings, it was suitable for use in this context. But there wasn't really an awful lot of in-depth critique of the theory, which we really had wanted to find. So we wanted to know what the difficulties were that had arisen when people had used the theory, because that's how theories evolve over time and are improved. There was just the one specific critique about the missing construct from the Malawi paper. So strengths and limitations, it was quite difficult. I'm saying that I didn't do all the nitty-gritty of it. We had a BSc student doing it, but I think she found it a challenge because it was such a broad review, and there were such a lot of different types of papers and settings, because clinical settings were very broad, lots of different ranges of long-term conditions. And so she found that the synthesis quite challenging. And there were a low number of low middle income papers. It was just the Malawi paper, but we did restrict to English language. And so that probably did have an effect, but it was a BSc project. We didn't have funding to translate. So key points, burden of treatment theory clearly does produce a useful lens for research focusing on both understanding treatment burden and developing interventions to lessen it. And it was most commonly used prospectively for data analysis or to underpin data collection methods. So people were actually thinking in advance, we're going to use this and then applying it to their research rather than at the end just sort of adding it in. And interestingly, because it was used across such a broad range of settings, it does appear that the theory is stable across a wide range of settings, including non-clinical, although that was only one paper. So it's obviously got high degrees of flexibility and adaptability. However, we do need more research to find out more about the theory itself. So clearly, going on from my last point, we need more research in low and middle income settings. That would be really interesting to see. And it would be good if we could see researchers critically engaging a bit more with the theory. I don't know why that doesn't happen. I don't know whether sometimes people are worried they're going to offend the authors of the theory. But hopefully we'll see more of that coming up. And it would be good to see more people using the theory outside the original research group that developed. I kept it nice and short for you. Okay, that's me. Thank you.
Great. Any questions? You know, like that?
Thank you very much for that. I was thinking about settings and different models of healthcare provision. Was there anything around, maybe you mentioned, I'm sorry if you did, around public and private provision and your insurance-based systems, etc.?
So
Sorry, can I just repeat that question
Yeah.
for the online audience? I don't know if they heard that. And that was a question regarding the difference in the healthcare settings, private versus.
Yeah, the type of systems, yeah, so
Yeah.
the NHS here versus insurance.
So is there a difference between the different healthcare settings?
So I think burden of treatment theory is probably most suited to the NHS setting, data point of because it was developed here, but it is flexible and can be adapted. So it had been used, like for example, in Australia, it was an Australian paper. It hadn't been commented specifically on whether it was suitable to their type of system, but it said it was suitable. So that's what I mean about the level of critique was probably too low to be able to say that. But it would be great to have more papers looking at those settings and seeing whether it was suitable. But they just said, yeah, this was useful. So not a lot to take from that, I guess. But I suspect it's more suited to the NHS at the moment.
Okay, so thanks for that. I wondered if you thought, I know it wouldn't be easy, but whether you thought about contacting any of the authors, because it might be that there's very little evidence in the papers that they kind of engaged critically, and they might have some reflection on something. I don't think quite
Just to repeat that question for online audience, is whether or not Katie had contacted the authors to find out if there'd been more engagement with the theory than what was just written in the papers.
I know, because they might be limited by word counts and such like, and yes. So we haven't done that. There is ongoing work. We are using this further. Carol May, who developed the theory, is actually going to use it and write it in a series of papers. So I'll say that to him actually, because it's a good point that maybe it would be worth us communicating with them, because I think he's going to go in depth with it quite a lot. But we hadn't done it. Again, we're a bit limited with the being a student project and things, but yeah, often what you see written in the paper is not necessarily the full picture.
They might have a lot of reflections that you can't put in the paper or.
Yeah, they've either not had the words, they might not have the words, or they might have been trying to be diplomatic. And there's also that conflict of interest of the authors being in the original author group as well. So that's why it'd be good to see more outside research.
We have one question online that we go to first.
I don't mind.
Ritesh.
Oh, hi, Tish.
Hi, Katie. So the question is, what were your expectations for future in terms of where do you think this theory could be, its use can be expanded beyond what you found?
So it's funny because Carol May, so for people in the room, is a sociologist, and a lot of the papers are very sociological language, which is quite hard for anyone who's not a sociologist to grasp. So he said to me today, he was hoping to make it a bit more accessible and publish papers that were accessible in the language of all people. But I mean, I think there's a lot of scope for it to have bits that you can take out and remove depending on what your healthcare setting is. I think the main purpose of it for the future will be intervention development. But there's quite a bit of work to be used and you know, quite a bit of work to do in the meantime to maybe refine the theory. Does that make sense?
Thanks, that's great.
And then we have one more question from the audience.
Yeah.
I would like to ask if it's possible to do meta-analysis for this to draw out the eventual answer.
So the question was, sorry for online, is it possible to do a meta-analysis to draw out further findings? I think.
Yeah, so so it's qualitative, they're all qualitative papers. So you mean a sort of like meta synthesis of qualitative work. So I guess this was very focused on the use of the theory. Actually, we are going to use the findings from the paper to do work that's going to answer more clinical questions as well. So that will involve more of that. Is that what you mean?
Overviews or reviews, I mean. Incorporate this section.
A review. So we did include systematic reviews in this though. I mean, there were 5, so I think when we're doing future analysis, we'll include the reviews in it. Yeah. I don't know if I answered your question there.
Any other questions from the online audience? I think so. Or I'd like to thank again all 3 speakers very much for presenting today, 3 really interesting talks. So thank you very much. If anyone wants to present on the cross-theme seminars where we have a different presenter from each of the research themes in the school, please feel free to contact the people for speakers. Thank you very much.
Yeah,